This is Dr. Hessel continuing with part 2 of my podcast on basic cardiac physiology, which was due on October 4th, 2016. I would now like to talk about the functional microanatomy of the cardiac muscle. As you recall, the muscle cell is called a myocyte, and it has a cell membrane and a cytoplasm. Inside it contains nuclei, mitochondria, myofibrils, and a tubular membranes, the T-tubules, which are extracellular, and the sarcoplasmic reticulum, which are intracellular. This diagram from Gray's Anatomy shows the shows the breakdown of the structure of muscle fibers, which would be similar to what is true in the myocardium. This shows the tubular system. The sarcomeres are attached end to end at the Z-bands, and inside the sarcomeres are the two components, the actin and the myosin. The actin are the thin filaments and the myosin the thick filaments. They bind to the myosin with globular heads, and activation causes flexion of these heads. There are also two regulatory proteins, tropomyosin and troponin, as summarized on this slide. This shows the heads on the myosin, and these fix to the actin, and by flexing cause movement. This shows the relaxed sarcomere in end diastole and the contracted sarcomere at end systole. Note the marked overlapping between the myosin and the actin in the contracted state. Troponin and tropomyosin cover the active states and prevent contraction. When a small amount of calcium enters the cell, this causes exposure of these sites and initiates contraction. Calcium is then pumped back, and this ends contraction. These phenomena are summarized in this diagram from Miller's textbook. Again, this diagram shows the interaction of the heads on the myosin molecule with the actin, and this illustrates the movement of these heads, causing the overlapping between myosin and actin. This movement of the myosin heads is illustrated in these diagrams from Barish's, from an earlier edition of Barish's textbook, and also from this diagram from Kahn's textbook. Finally, this shows the relationship of the thick myosin filaments and the thin actin filaments at end diastole and at end systole, and shows what would be observed on electron microscopy. Let's move to another topic then, namely comparison of the right ventricle with the left ventricle. In the anatomy section, I talked about the difference anatomically. Functionally, however, remember that the right ventricle has a steep Starling curve being extremely sensitive to preload, and the left ventricle has a more shallow function curve. The right ventricle is predominantly a volume pump, whereas the left ventricle is a pressure pump. The right ventricle is very sensitive to afterload, which of course is determined by pulmonary artery pressure, whereas the left ventricle is relatively insensitive to afterload. Conversely, the right ventricle is more sensitive to preload than is the left ventricle. There's this important relationship between the right ventricle and the left ventricle called interdependence. Since they share a myocardium and an interventricular septum, they also share the volume within the pericardium. And so expansion of one causes contraction, causes limited space for the other, and vice versa. There's also the impact of respiration. On arterial pressure. During inspiration, venous return increases, which increases filling of the right ventricle and ultimately movement of blood into the left ventricle. Respiration also influences arterial pressure, and this is become practical as a monitor of volume status. When patients are hypovolemic, there tends to be a large respiratory effect on arterial pressure, whereas when they are full, there is less effect on arterial pressure. Let us then turn to the autonomic nervous system and the heart. The first messenger is so-called catecholamines, which are epinephrine and norepinephrine. They bind with G proteins, stimulating increased contractility in the heart, as well as increased heart rate and increased relaxation. On the other hand, stimulation of the inhibitory G proteins inhibit acetylcholine and cause relaxation and vasodilation. There are alpha and beta receptors in the heart. The alpha receptors in the coronary arteries cause vasoconstriction, while in the myocardium they have an inotropic effect. The beta receptors in the coronary artery cause vasodilation, and in the myocardium cause increased contractility. Chronic catecholamine stimulation results in downregulation of beta-1 and less regulation of beta-2 and no impact on alpha receptors. The parasympathetic stimulation of the heart predominantly acts on the conduction system, where it causes decreased rate and decreased flow. In the myocardium, it may cause decreased contractility. And in the coronary arteries, it has been found to cause both vasoconstriction and vasodilation. Let us now turn to the principal cardiac reflexes, specifically the effect of sympathetic and parasympathetic stimulation. First, let us talk about the high-pressure baroreceptors. These are located in the carotid sinus, the aortic arch. The impulses pass through the glossopharyngeal and vagal nerves to the cardiovascular center in the medulla. Low pressure stimulates the sympathetic nervous system and inhibits the parasympathetic nervous system, and also causes release of vasopressin. Well, high pressure in the high pressure baroreceptors cause the opposite effect. This diagram from Barish's Clinical Anesthesia Fundamentals depicts the baroreceptor high pressure, the baroreceptor reflexes. You see the receptors in the carotid sinus and the aortic arch go up to the medulla, where it then has effect on heart rate and on peripheral vascular resistance. I previously showed the effect of changing arterial pressure on sympathetic and parasympathetic activity. Increasing arterial pressure causes increased vagal activity, and a decrease in arterial pressure causes an increase in sympathetic activity. Let us then turn to the low pressure baroreceptors. These are located in the atria, especially at the veno-atrial connections, but also in the ventricles. The afferents pass via the vagus nerve to the medulla. Low pressure in these receptor sites stimulate the release of vasopressin, while high pressure in these receptor sites causes the Bainbridge reflex with an increase in heart rate and the secretion by the heart of ANP, BNP, resulting in natriuresis, diuresis, and vasodilation. Let's then turn to some of the other reflexes. This summarizes cardiac reflexes that affect heart rate, the afferent sensors and the efferent response. We show the baroreflex, the atrial or so-called Bainbridge reflex, the chemoreceptor, the oculocardiac, and the Cushing reflexes. The carotid sinus reflex we've already talked about. Increased arterial pressure inhibits the sympathetic nervous system and stimulates the parasympathetic, resulting in decrease in arterial pressure, decrease in heart rate, and decrease in contractility. Decreasing arterial pressure results in the opposite effect. The chemoreceptor reflexes are located in the carotid and aortic bodies. They respond to low PO2 and pH. Afferent signals travel up the nerve of Herring, cranial nerve 9, and the vagus to the chemosensitive areas in the medulla. It results in stimulation of the respiratory center, causing stimulation of respiration. And the parasympathetic system causes decreasing heart rate and contractility. Note the hypoxia and acidosis in the central nervous system directly stimulates the sympathetic nervous system with tachycardia and hypertension. The oculocardiac receptor, the stimulus is pressure applied to the globe or retraction of the extraocular muscles. The afferents go via the ciliary nerves and the ophthalmic division of the trigeminal to the Gasserian ganglia, where it stimulates the parasympathetic nervous system, causing bradycardia. It may also influence the Bainbridge, Bateshold, Jared, Valsalva, and Cushing reflexes. The Bainbridge receptors are stretch receptors in the right atrium, especially at the junction with the cava. The afferents run in the vagus to the cardiovascular center in the medulla. Increased stretch in the right atrium results in inhibition of the parasympathetic nervous system and an increase in heart rate. The Bateshold-Jared responds to noxious ventricular stimuli, which are sensed by chemoreceptors and mechanoreceptors within the left ventricular wall. The afferents travel in the vagus and result in increased parasympathetic tone, resulting in hypotension, bradycardia, and coronary vasodilation. It may explain some of the responses to myocardial ischemia, infarction, thrombolysis, and revascularization. The Valsalva reflex says that positive intrathoracic pressure decreases venous return and decreases cardiac output and systemic arterial pressure. This stimulates the baroreceptors to increase heart rate and systemic vascular resistance and contractility. Upon release of postural pressure, there is an increase in venous return, results in an increase in cardiac output, arterial pressure, and the baroreflex, leading to a decrease in heart rate. The Cushing reflex reflects what happens with an increase in ICP, which leads to cerebral ischemia in the medullary vasomotor center. This leads to activation of the sympathetic nervous system with increasing in arterial pressure, causing hypertension and tachycardia. The carotid sinus reflex results in parasympathetic stimulation, causing reflex bradycardia. And finally, ischemia of the respiratory center leads to irregular respiration. So hypertension, bradycardia, and irregular respiration are the consequence of the Cushing reflex. Next, let me turn to control of effective circulatory volume, or total body sodium. The receptors are the high and low pressure baroreceptors and the kidney. In response to a true decrease in extracellular fluid or a perceived decrease in extracellular fluid caused by decreased perfusion and hypovolemia, there is release of vasopressor hormones, including vasopressin, renin-angiotensin, norepinephrine, and epinephrine. The vasopressin results in increased water and sodium reabsorption. The renin results in increased sodium reabsorption, and norepinephrine decreases glomerular filtration rate and increase in sodium reabsorption. All of these then lead to sodium retention in an effort to restore intravascular volume. This schematic summarizes the effect of hypovolemia and how these are manifested and mediated. Hypervolemia suppresses the output of vasopressor hormones and stimulates the release of natriuretic peptides. These result in natriuresis, diuresis, and vasodilation. Again, this shows diagrammatically the responses to hypervolemia. A few words about the pulmonary circulation. This has a huge potential bed. It is a low-pressure system, has very low resistance, and there are also bronchial arteries and veins. Pulmonary artery pressure equals the pulmonary venous pressure plus the pulmonary vascular resistance times pulmonary blood flow. Hence, pulmonary artery pressure is influenced by three factors: pulmonary venous pressure, pulmonary vascular resistance, and pulmonary blood flow. Normally, of course, pulmonary blood flow is the same as systemic blood flow. And normal pulmonary artery mean pressure is somewhere between 9 and 20, but the upper limit of normal, or the definition of pulmonary hypertension, is considered 25 or greater. The general formula for pulmonary vascular resistance is mean PA pressure minus pulmonary artery occlusion pressure divided by pulmonary blood flow, which is usually the same as systemic blood flow. Notice that there is a parabolic curve to vascular resistance versus lung volume. Pulmonary vascular resistance is lowest at normal FRC. As lung volume falls below normal, pulmonary vascular resistance goes up, and conversely, as lung volume increases above normal FRC, vascular resistance increases. Normally, pulmonary artery pressure does not increase much in response to increased pulmonary blood flow. Pulmonary vascular resistance normally decreases in response to physiologic increases in pulmonary blood flow. This is not mainly due to vasodilation, but due to the recruitment of more pulmonary vessels. On this slide, I've summarized again the hemodynamic causes of increased pulmonary artery pressure, namely increased pulmonary venous pressure, increased pulmonary vascular resistance, or increased pulmonary blood flow. The pulmonary vascular resistance can be reflected by the gradient between the pulmonary artery mean pressure and the pulmonary artery occlusion pressure. Note that I have erroneously misarranged the increased pulmonary vascular resistance gradient. It should be pulmonary artery mean pressure minus pulmonary artery occlusion pressure. On this slide, I have summarized some of the causes of these three hemodynamic abnormalities. The bronchial arteries and veins supply nutrition to the airway. The venous drainage of the proximal flow is into the systemic veins, the azygos and hemiazygos. However, the venous drainage of the distal bronchial pulmonary capillaries, the distal capillaries from the bronchial arteries is into the pulmonary vein. This results in a small right to left shunt equivalent to about 100 milliliters per minute, or about 2% of the cardiac output. Let me then turn to the peripheral vascular system and first talk about the arterial pulse wave. The arterial pulse wave is influenced by stroke volume and modified by the rate of ejection, the compliance of the arterial system, the impedance, and the systemic vascular resistance. There are also noticeable changes of the arterial waveform as we move down the vascular tree. These are summarized on this slide. The sharp dicrotic notch becomes more scooped. Systolic pressure increases, diastolic pressure decreases, pulse pressure increases, but mean arterial pressure falls very slightly. This diagram from Barish shows the changes in the arterial waveform as one moves progressively down the arterial system, and this is another diagram from an earlier edition of Barish's textbook. This slide nicely summarizes the various vascular beds, including those in the head and neck, those in the pulmonary circuit, those in the hepatic and portal veins, mesenteric vessels, pelvic, and legs. This diagram shows what happens to the anatomy of the vessels as one moves through the arterial system. Note the change in the amount of elastic tissue, smooth muscle, and fibrous tissue, and also the caliber of the vessels. This diagram shows the progressive fall in blood pressure as one moves down the arterial tree. Most of the fall is in the small arteries and the arterioles. This shows the changes in intravascular pressure, velocity, cross-sectional area as one moves from periphery, from central to distal vessels. This is a diagram of the microcirculation going from the arterioles to the venules. Note this very complex interrelated system of capillaries in the tissues. This diagram shows the various enzymes in the various components of the peripheral tissues, arteries. Fick described diffusion through semipermeable membranes as summarized on this diagram. And Starling, at the beginning of the last century, described his hypothesis of the movement of fluid between the proximal capillaries and the distal capillaries, and said it was governed by the difference between the pressure inside and outside the capillaries and the oncotic pressure inside and outside the capillaries. And the oncotic pressure, which is determined by these various factors. This is a classic diagram from the latest edition of Barish's Clinical Anesthesia Fundamentals, illustrating the Starling hypothesis, suggesting that in the proximal portion of the capillary, the hydrostatic pressure exceeds oncotic, and so there's flow out of the vessel into the periphery, whereas at the distal end the reverse occurs. However, and this is another diagram showing this same phenomenon with the fall in hydrostatic pressure causing filtration in the proximal portion and absorption in the distal portion. However, this hypothesis is found to be imperfect, and this is attributed now to the presence of the glycocalyx, which lines the endothelium of the microcirculation. The glycocalyx is located on the surface of the endothelial cells and is present throughout microvascular beds. It contains various hormones which are important as and enzymes which regulate movement of leukocytes and thrombocytes. It also influences vascular permeability and finally adjusts the oncotic pressure that is seen by the fluid inside the vascular tree. This nice review article shows a picture of the normal glycocalyx and the injured glycocalyx. It is thought that the glycocalyx and its function highly influences the development of peripheral edema in disease states, and also alters some of the assumptions of the Starling hypothesis. In fact, it purports that there is no oncotic movement of fluid from the interstitium back into the distal capillaries due to oncotic differences, but that almost all fluid resorption is via the lymphatic system. These figures displaying normal and abnormal glycocalyx are from this review article by Woodstock. And finally, he has summarized the implications of these new concepts about the Starling hypothesis. Pulmonary edema is due to an increased production of interstitial tissue. On this slide, I have summarized some of the factors that influence the production of interstitial fluid in the lung, and factors that are essential for its removal. And one of the most important is central venous pressure and lymphatic function. The classic causes of pulmonary edema are either increased pulmonary venous pressure, in other words, wedge pressure, or increased permeability. But there are other types of pulmonary edema in which the cause is less clear. And the role of oncotic pressure, lymphatic function, and negative pressure and neurogenic factors are not entirely understood. Finally, let me close with a few comments about heart failure. There are various ways of looking at ventricular function. You can look at the right ventricle or the left ventricle. You can look at the myocardium versus the pump. You can look at systolic function versus diastolic function, global versus regional, a function at rest versus when stressed, and from the standpoint of the body, namely forward cardiac failure versus backward cardiac failure. Forward cardiac failure means decreased cardiac output, and backwards cardiac failure means increased pulmonary or systemic venous pressure. I've already summarized some of the ways of estimating the contractile state of the intact ventricle and suggested that this elastance is perhaps the most favored method of estimating function of the ventricle. I also gave you this pragmatic definition of heart failure, or I offer this pragmatic definition of heart failure. Heart failure is present when the heart is unable, with acceptable filling pressures, to maintain adequate cardiac output to meet the metabolic needs of the host at rest or with exercise. In response to heart failure, there is early adaptation, which is an effort to maintain cardiac output. And this utilizes the Frank-Carling mechanism of increasing preload by retaining fluid and neurohumoral responses, such as of the sympathetic nervous system, renin and AVP, and also ANP and BNP. Unfortunately, after time, these compensatory factors become maladaptive. This includes remodeling of the heart. It dilates, it changes its shape to become spherical, it develops hypertrophy, the myofibrils slip, you develop interstitial fibrosis and collagen deposition, and loss of myocytes. There's increased wall tension, increased diastolic stiffness, and decreased contractility. Other manifestations of late maladaptation is downregulation of beta receptors, endothelial dysfunction, release of cytokines, increased production of angiotensin, loss of antioxidant defense mechanisms, mitral regurg, atrial fibrillation, and re-entry arrhythmias, including sudden death. Finally, the kidneys malfunction, retaining sodium and becoming unresponsive to atrial natriuretic peptide. Some of the therapeutic implications of these maladaptive phenomena is the use of ACE inhibitors, beta blockers, aldosterone blockers, and other experimental modalities, and most recently, the innovation of controlling heart rate to treat heart failure. That completes part 2, and at the end I have study questions that relate to both part 1 and part 2. And that completes this presentation. Thank you.